Our first speaker this morning is Dr. Joan Bathon. Joan is Deputy Director of the Division of Rheumatology and Adjunct Professor of Medicine, or wait a minute, this is last year's. She's now Director of the Division of Rheumatology and Professor of Medicine at Columbia and was at Johns Hopkins. She received her bachelor's degree at Marquette, her medical degree at the University of Maryland. She was an intern and resident at Maryland and postdoc fellow in rheumatology at Johns Hopkins. She was then at West Virginia. I don't think, Joan, we could count you for the West Virginia person. She was then been at Hopkins, as we all know, for a number of years. She's received the Mary Betty Stevens Award for Excellence in Clinical Research. She's a reviewer for numerous NIH and other study sections, numerous peer-reviewed publications, and she's been a past member of the FDA Advisory Board. And this morning she's going to talk to us about the conundrum of choices in the treatment of rheumatoid arthritis.
Well, thanks, David, for the invitation to come and talk here at this lovely resort. I've always enjoyed coming here. And you gave me a really tough topic, trying to help sort through the many treatments that we have available for rheumatoid arthritis and how to, hopefully in an evidence-based way, select our choices. So there are almost no data on comparative effectiveness. The best way to choose our selection of choices for the treatment of RA would be if we had comparative effectiveness from one drug to the other, and we have almost no data on that. So what I've done, I don't want to do what Ted Pincus calls an eminence-based discussion as opposed to an evidence-based discussion. So what I've done is I've tried to cherry pick a couple of items that I thought might be useful to consider in our deliberations of choosing drugs. So the first is just addressing some guidelines, and the new EULAR RA treatment guidelines have come out, and I thought I'd review a couple of points with that. Also, what should our goal of treatment be? I think we all would agree that if we can, we should achieve remission, so I wanted also to review the new remission criteria. And then I'm going to go through a couple of just select points that might help our decision-making in terms of one biologic versus another. So you may remember that when the ACR guidelines came out in 2008, there was a lot of consternation. I wasn't on this committee, but I did write the editorial just pointing out some of the problems with it. And you may remember that there was this dizzying array of algorithms that selected, they were totally evidence-based, and that was a wonderful thing, but it left a lot of holes. And so on evidence-based, they could only go for conclusions that were based on the criteria of inclusion and exclusion of patients in individual studies. So what we ended up with for use of non-biologics are 3 different algorithms depending on whether the patient had early, mid-level, or advanced disease. And same way for biologic DMARDs, we ended up with these complex algorithms depending on what stage of disease patients were in. So they were each a snapshot of particular groups of patients, but that's not how we care for patients. We care for patients in a continuum with decision-making at every turn. So these had some issues and flaws, but the committee really wanted to stay evidence-based and didn't want to make the connections between the dots if there was no data. Well, what some of us tried to do is get around that with adding a little eminence-based material to it. And so John Giles and I wrote the chapter on treatment of synovitis in the Hochberg textbook where we tried to come up with an algorithm. And I'm not going to spend time on it because I think the EULAR guidelines actually do that better. So these were published last year in Annals of Rheumatic Disease. And they took a little bit of a different stance than the ACR guidelines in that they only dealt with efficacy, not safety, which you could argue is not the way to make a decision. You have to always weigh both. And they used evidence-based where available, but where not available, they did add expert opinion to connect the dots and try to come up with a continuum of recommendations. And it's always important to note that, of course, the healthcare systems are different. So in a different regulatory environment, a different financial environment, the recommendations might not be applicable to the US. So I scanned these from the article, so I can't take credit for the fuzziness. Apologize for that. But here's what they did is they divided treatment of RA into 3 phases. And this is, I think, really mimics what we already do in private practice. So it's based on evidence, but it's based on practical approach to patients as well. So once You make the diagnosis of RA. If they have no contraindications to methotrexate, start methotrexate. That's a no-brainer. If there's a contraindication, you use a different non-biologic leflunomide, sulfasalazine, and they add intramuscular gold. I don't know if any of you still use gold. And then your goal would be to achieve target, whether that's remission or low disease activity, within 3 to 6 months. But if they fail that, then you go to phase 2 and come in here where you failed the initial DMARD. And if the patients don't have bad prognostic factors for bad outcomes in RA, they could go to a second non-biologic DMARD or even add a second biologic DMARD. And we'll come back to this point in a minute. If they have bad prognostic factors, which you all know of, high titer rheumatoid factor, high titer anti-CCP, high SED rate, a lot of swollen joints, early erosions on X-ray, then you would add a biologic. Again, that's no-brainer. We know that already. Again, trying to achieve a target within 3 to 6 months, but if you aren't able to do that, then the next is phase 3, in which the recommendation is either to change the biologic, so take your TNF inhibitor, switch it to a second TNF inhibitor, or add one of the other available agents, abatacept, rituximab, and tocilizumab. And then if you fail that, well, then we get into the next talk on the new biologics, and you enter your patient into a clinical trial. Well, actually, probably you try all these different drugs, right? One after the other with no real guidance on how to do that. So a couple of points about the EULAR guidelines is that they recommended starting a non-biologic DMARD as soon as the diagnosis of RA is made. We probably do that already, but the one modification in these guidelines is start it as soon as the diagnosis is made based on the current classification criteria for RA, and I'm going to go over those in a minute. So that moves the bar closer, earlier. And then treatment target should be remission, and if you can't achieve that because of too much toxicity with drugs or whatever, then you accept low disease activity. And then we'll talk about these remission criteria. And I think one of the interesting things that I found in this paper is that they recommended that if the patient doesn't come into remission or low disease activity on the first DMARD, they suggested switching it to a different non-biologic DMARD as opposed to adding a second biologic DMARD. This is for patients that don't have bad prognostic factors. So if they fail methotrexate, you switch to sulfasalazine or switch to leflunomide, where I think many of us would add that. And their argument is that they did a meta-analysis in which, when they looked at combination therapy of non-biologics versus methotrexate alone, they found that the advantage of combination of non-biologics was often driven by steroids and not the addition of the second non-biologic DMARD. I reviewed a meta-analysis also from the ARHQ in the US, and they had the same conclusion, that prednisone was really driving the advantage of combinations of non-biologics. So there's a paper coming out in ANR that contends that doesn't agree with that, but anyway, it's an interesting twist on this story that I had not actually heard before, and it takes a meta-analysis to really come up with those kinds of information. All right. And they went so far as to say that if a patient is in persistent remission off steroids, to consider tapering and discontinuing the biologic DMARD. And some of us do that already, and that was driven, I think, a lot by the BEST trial, in which they had patients in remission for a long time stop the infliximab, and a lot of those patients were maintained in remission. They even go a step farther in saying in cases of sustained long-term remission, cautious titration off non-biologic DMARDs could be considered. It's a very tentative statement. Very little data on this to support that, but a cautious statement. So just to remind you that, again, the EULAR guidelines said start DMARD, non-biologic DMARD as soon as you make the diagnosis, and using the 2010 revised criteria for classification of RA. And these are classification criteria, not diagnostic criteria. The difference here is diagnostic criteria will take all comers with joint pain and separate out RA from everything else through an algorithm. Classification criteria assume that you've already ruled out a lot of those other causes. So the target population that they tested for these classification criteria are patients that had one joint that was swollen, and synovitis could not be better explained by any other disease like gout, psoriasis, whatever. And remember, these criteria add up. You have to have 6 out of 10 to be considered definite RA, and the points are are organized by increasing